Hi, I appreciate everybody coming out and listening to us talk about something that Dr. Osman and I are pretty passionate about. We both, let me put that over there for now. When I first came back, I met Dr. Osman and got to talk to him a lot, and we both kind of realized that we liked to try to help people that had lung cancer. And one of the things that we wanted to do was help people that had early stage lung cancer that we could really do something about. And so we've worked and we've worked together, both an employed physician at the hospital and a private practice physician in a multidisciplinary setting, and created a pulmonary nodule clinic. And then now we've engaged in actually lung cancer screening, and they're two separate things, and we'll kind of talk about them a little bit. But we wanted to tell people why we think it's important, and we wanted to brag a little bit because we think we do a really good job at it. And so we wanted to let you know how good of a job we do, and hopefully you'll appreciate why it's important to screen for lung cancer. So basically the first question is it right for me? People have asked me a bunch, should I get screened for lung cancer? And we'll cover some of the rationales for why you should be screened and who should be screened as we go along. And I'm going to present a presentation that we've put together from our thoracic surgery office. Dr. Osman has some slides that he's put together from his pulmonary medicine side of things. So we kind of see things from a different perspective, which we constantly learn from each other. So here's who's going to be here tonight. This is Rhonda. She's our nurse practitioner, helps us run the pulmonary nodule clinic. So if you do get engaged with us in any way, she's often the person in the office, sees some of the people, calls people, and talks to you on the phone a little bit too sometimes. So lung cancer is one of the #1 cancer killers. It's a cancer that we still haven't gotten as good of a hold on as we have some of the other cancers. And so lung cancer is still a significant disease, and it does kill a lot of people. If you look at all the cancers, the percentage of people that die from lung cancer is higher than it is from some of the other lung cancers. It passes breast in females, and it passes prostate in men. This is some estimates, just some numbers. A lot of people, like I said, die from lung cancer. In Pennsylvania, 8,000 people a year die from lung cancer, and that's a significant number. Those are our neighbors, people who live near us, friends, co-workers. Those are people around us, and that's a big number, and it's an impressive one. The reason people die from lung cancer, smoking is a #1 risk factor. Everybody knows that. Second, which still gets a lot of press and people may or may not know, it's still a significant part there, is radon. And then there's a whole host of other things that account for the rest of lung cancer. Now, as far as frequency of cancer, we talked about it being the most common cancer killer. It's the second most common cancer. So even though people don't get it as much, still more people die from it because we haven't gotten as good of a control at treating it as we do. People live longer when they have prostate cancer or breast cancer. They tend to live longer with colon cancers. The chemos are better at controlling those cancers. And that's why it's so important to find it early, because that's your best chance. And so that's when we talk about pulmonary nodule clinics and lung cancer screening. New cases. So every year there's going to be about 11,000 new cases. But every year, 8,000 of those people that were diagnosed previously are going to wind up not making it. And that's staggering statistics, and that's what we want to try to change. And the reason why lung cancer is so deadly is because it's difficult to treat. Lung cancer tends to be a more aggressive cancer for most part. There are some milder forms, but it's only curable in its early stages. If you have advanced stage lung cancer, chemo and other options usually are more in the palliative sense. They can control it, they can slow it down, but you're not going to get a cure. And often there's a delay in diagnosis, and we'll explain a little bit about why there's a delay in diagnosis. So here's some more reiteration of what I just said. Many forms are aggressive, traditionally poor response to chemo and standard radiation, and recurrence. The recurrence rate for lung cancer is unfortunately higher than we want to see it. So if a malignant solitary pulmonary nodule, and by nodule what I mean is anything less than 3 centimeters by definition is a nodule. If you find a spot on your lung and it happens to be a cancer, if it's less than 3 centimeters, 2.5 centimeters is an inch, so if it's less than that, it's considered a nodule by definition. Over that, we start to call it a mass, just so you have some idea of the size of what we're talking about here. If it's resected early, the prognosis is pretty good. It's 70 to 100% 5-year survival, so that's not so bad when you're talking about a malignancy. When you get beyond that, it drops off pretty dramatically. And these are some of the recurrence rates. If it's the stage distribution for these lung cancers is when we find them. You see 56% of people when they're diagnosed with lung cancer, already have distant metastasis. And that's one reason why lung cancer has such horrible prognosis, is because we don't often find it early. When we find it early, it's usually accidentally. Usually you're having a CAT scan or an X-ray for something else, and we find these nodules. If you come in and you have symptoms and we find your lung cancer, it's because usually the cancer is advanced. If you're coughing up blood or you have pain in your chest wall, usually you don't have a nodule. Usually at that point you have a mass that's enlarged and it's causing you symptoms. And so our ability to control that or cure that is really, really reduced at that point. So, same stuff, lack of symptoms. Lung cancer usually causes no symptoms. These small nodules don't give you any symptoms, and so people don't go get scanned or an X-ray or anything because you have symptoms. Most of the people we see went to the ER for belly pain, or they showed up in their doctor's office and they got sent in for something else, and then they incidentally find these nodules. The other main thing here, and this is a huge change in the last 6 months, is up until then there was no lung cancer screening. There's been studies in the past where they had people cough up sputum and they tested it for cancer cells. That didn't work. X-rays haven't worked. And in some smaller studies, just CAT scanning smokers hasn't really worked. It hasn't shown a big enough benefit to be worth the cost of the radiation exposure and all that stuff. However, CAT scanning's gotten a lot better, and our understanding of lung cancer has gotten a lot better. And so we finally, this past year, a large study was done that's changed all that. The whole landscape is now changed. So lung cancer screening is now becoming a reality. Up until this year, there was no screening. If you turn 50, you get your colonoscopy. If you're a female, you get your mammograms, prostate exams. Most other major killer cancers have some sort of screening modality. You go to your family doctor, he pushes it, recommends it. Early detection is the key for almost all cancers. But up until this past year, there was nothing for lung cancer. All right? And inadequate follow-up. A lot of times these small nodules get found because people did present to the ER and you were more concerned about the belly pain or something else you had going on, and oh, by the way, you have a nodule. And people would forget about that, and so they wouldn't get follow-up. And so sometimes these little nodules got lost, and then people showed up later with more advanced disease. So that's why we just think it's really important to have a pulmonary nodule clinic in place and talk about screening, because screening's new. It's just shown up this past year. Just a little bit about lung cancer. There's 2 major types, and I'm not going to bore you too much with the details of that. One type is much more agreeable to us operating. The other type is something that we really can't do much for surgically. It's more of a chemotherapy kind of thing. And that difference is small cell and non-small cell. We favor the ones down here for surgery. These small cells are more for chemo. The survival rates by stage, the stuff mentioned before. If you have early stage disease, and there's 4 stages, by the way, 1 through 4. So if you're early stage and we can find it early and we can take it out, your 5-year survival is pretty good. If you get to these advanced stages, you can see it drops off pretty big. If you show up and you have disease spread throughout, the 5-year survival is very poor. And so we really, really want to find people with early disease, okay? And this is just sort of a reiteration of some 3-year survival and stuff. And this is something I've mentioned before, but colon, breast, prostate cancers all have benefited over the last 10, 15, 20, 30 years with improved survival, and it's all been linked to when screening has been initiated for those cancers. And so if you look at this graph, I know it's a little bit busy and I apologize, but kind of if you look back at the survival rates in the 70s for some of these cancers, they're not that good. But if you look at some of the more common ones, if you look at breast cancer, the survival's improved over the last 20 to 30 years, colon cancer's improved, and prostate cancer's improved. Now this counts people that showed up with early stage, late stage, and that's why these numbers aren't that good, is because you're taking everybody, even people that had really bad disease when they showed up. So we want to find people, I can't say it enough, that have early disease. It really is what we're going after here. There's a trial that was done a while ago on lung cancer screening, and we knew that it was going to be helpful because 85% of the people that they found in this screening trial had stage 1 lung cancer. So they found a lot of people with early disease, and when they were able to do something about it, if those people underwent resection within 1 month of the diagnosis, their survival rate was 92%. So we know if we find it early and we can do something about it soon, we can help people. And that's what we want to do. Now that there wasn't a strong enough benefit in the amount of population that they had to screen. And this was at an older time when the radiation dose was much higher. And so the benefit and risk wasn't there to really make a statement and say lung cancer screening should be done. And so, and also the person that did that study took money from the tobacco industry, and so the study was a little bit discredited. So the National Cancer Institute recently sponsored a study that's been going on for a few years, and this is the one I was talking about, that the results were released this past year, and it sort of changed everything for us. This study enrolled 53,000 people across the country. It's a huge amount of people. And they screened people that were age 55 to 74, and they were either current smokers or had quit within the last 15 years, and you had to have smoked about 30 pack years. And that means you smoked 1 pack a day for 30 years or 2 packs a day for 15 years, but you had the equivalent of a 30 pack year of smoking. And in this study, they showed they could reduce death rates by 20%. And so that was huge because it showed a huge benefit, and enough of a benefit. And this was an unbiased study, and so nobody picked it apart for the most part. And so this is sort of our latest release of information when it comes to lung cancer screening. And so lots of people have started doing it. In addition, most of the institutions that did this study across the country, as soon as this result was released, began to do their own lung cancer screening programs, and so have other institutions. And Pinnacle, I'm proud to say, is the first institution in this area. And once we had this data and we had a chance to analyze it, we got together with our radiologists, our pulmonologists, thoracic surgeons, and we put together our protocols, and we were able to establish lung cancer screening. And we're kind of proud to be able to offer it to the community and be the first place in the area to offer it. One of the things that's important about this is that it's the low radiation dose. For this study, it's not like a normal chest CAT scan where you get a large dose of radiation. So it's only 1.5 compared to 7 to 10, and these are millisieverts, some radiation physics stuff that I don't quite understand. But you can see how many chest X-rays it's equal to. It's equal to 15 chest X-rays or 16 months of background radiation. That seems like a lot, but if you're looking at a standard chest CT, which is what you'd get if you went to most institutions and got a chest CT, you're talking 90 chest X-rays or 2 years of background radiation. So the dose is much, much reduced. And we had to do some work with the radiology department, and we mirrored the protocols they used in this national study because those are the doses they were using. And they got very good results. The images are actually really nice. I was the first person to throw myself on the scanner as a guinea pig so that they could make sure they had everything figured out quite right. And I do not have any nodules. I was so thankful, so thankful. So we've mentioned the word pulmonary nodules, and some people may not really understand what we mean by that. That is a pulmonary nodule. A pulmonary nodule can be 1/10 that size, or it can be a little bit bigger than that. That's probably about 1.5 centimeters or so. It's irregular shaped often. Some of them are smooth shaped. They come in all kinds of different styles and characters. And when we look at the CAT scan, sometimes its appearance helps us decide whether we think it's more infectious, whether it's benign, whether it's malignant or not. And just because you have a spot or a pulmonary nodule doesn't mean it's cancer. Okay? That's important because pulmonary nodules can come from people that grew up in the Midwest. You can have things called histoplasmosis, which can make little spots on your lungs that then your body heals and they show up like this. So there's a whole bunch of different things. It doesn't have to mean it's cancer. The American Cancer Society has come out with some statements because of that study that was released and talking about lung cancer screening. And one of the things that I'm happy to say is they said that this should be done in an organized screening program at an institution with expertise in CAT scanning and access to a multidisciplinary team skilled in finding and treating abnormal lung lesions. So they said, okay, it's good to screen. Well, they didn't come out and say it was good to screen partly because it's going to be very expensive. And so there's some debate going on like who's going to pay for this, and so like everything, and there's no money in Washington right now, and so none of these national organizations have said you absolutely must screen yet, and that's why insurance doesn't pay for it yet. But what they did say is if you're going to screen, don't just randomly screen and then not know what to do with what you find. If you're going to screen, it needs to be in a setting of some expertise so that you're not just sending every single lung nodule for a biopsy. If you do that, you're going to biopsy a lot of things that don't need to be biopsied. And when you do biopsies, they have risks involved. It's a procedure. And so if you want to get that 20% survival benefit at the very low risk, it needs to be in the setting of a multidisciplinary team, which is what we spend a lot of time and energy setting up at Pinnacle. Dr. Osman's part of it. I'm part of it. There's a handful of other pulmonologists that you can see in this brochure that are part of it. We have interventional radiologists that are part of that. And we think that we're the right institution in the area to do lung cancer screening because we have this pulmonary nodule clinic that can help facilitate this stuff. All right. Now, the one organization that did come out and strongly recommended for lung cancer screening is the International Association for the Study of Lung Cancer. And they've had some studies in other countries that have shown some benefit, but this U.S. study was the first study that showed such a strong benefit in our country. And so they embraced that study and said, yeah. But they also said, good idea, go ahead and screen for lung cancer, but make sure it's done in the setting of a group of experts. Don't just randomly go out and screen and have people not knowing what to do with what they find. So we're proud to say we have lung cancer screening and we have a pulmonary nodule clinic to back it up. So here's who needs to be screened or who's recommended to be screened. 55 to 74 smoked 30-pack years or 2 packs a day for 15 years, half a pack a day for 60 years, however you want to work it out. This is the number that you can call and you can get set up for lung cancer screening if you're interested or if you know somebody that's interested. And Pinnacle was able to work out the cost to keep it as low as we could, which is much less than what it costs normally to go and get a CAT scan and much less than your insurance company gets billed if you get a routine CAT scan or something like that. And as a service to the community, we're able to do it for $99, and that includes the radiologist reviewing it and evaluating it. And if you get found to have pulmonary nodules, then it sort of drifts into the pulmonary nodule clinic and we try to follow it up. Because that's one of the big keys is making sure it gets followed up, because you'll need scans down the road to see if it's changing or growing and then to decide whether we need to do something about the pulmonary nodule, whether it needs a biopsy or not. And this is our multidisciplinary team, and multidisciplinary means we like to have people from surgery and pulmonologists that have medicine backgrounds, and so we look at things a little differently, and so we help each other. We blend well together. And we have interventional radiologists. Those are the guys that do the biopsy work. And then we have our nurse practitioner, Rhonda. We have a lot of cutting-edge technology. We got some very good PET scanners, which are special CAT scans that help light things up and help us decide who needs biopsies. We're able to analyze these nodules with some fancy software, which helps us once again decide who needs biopsied. We have not initiated this, but we should soon here. This is our fancy state-of-the-art CAT scan guided bronchoscopy, which allows us to go down through your airway and biopsy some of these nodules. We're getting this in place. This is another bronchoscopy tool that allows us to go down your airway and check, and helps us decide if people have advanced or metastatic disease, which means that cancer spread. We're trying to find less invasive ways to check people and find out exactly how much disease there is or isn't if it turns out your nodule's malignant or cancerous. We do minimally invasive surgery, which helps. It's less postoperative discomfort, fewer postoperative complications, faster recovery. We have robotics that we're incorporating into our lung cancer surgery now at Pinnacle. We have CyberKnife, which is one of our, we're the only institution, I believe, still in the area that has CyberKnife. This is radiation for cancer, and it's a very directed radiation beam, very high dose, but it only targets the area that we set it to. And so you don't have to radiate an entire chest to treat a small lung cancer. You can focus right down on that cancer and destroy that cancer without destroying a lot of lung or other tissue around it. And it allows us to do a a lot of really unique things in the area that other institutions can't offer. And it's a very valuable tool for patients that can't have surgery or don't want surgery. They can have this done. And it's showing some remarkable, use the term cure quite yet, but it's showing some remarkable results. It's very impressive. We also do a lot of stuff in the operating room, sending off tumor pieces of the tumor for fancy testing so that we can try to tailor chemotherapies for people. It's one of the things that we're working on. And I was just going to give you a case. This is the thing that I see every month, every other month. Somebody comes into my office with lung cancer, and unfortunately this lady didn't come into my office. I met her in the emergency department. 45-year-old. She had been in the emergency department in October 2009 with some complaints, and she got an x-ray while she was there. And on her x-ray, she had this very small thing, and it was reported out as a possible pneumonia versus a possible nodule. She didn't really understand and went about her business and never had any other follow-up. And that's the kind of stuff I want to prevent from happening with the pulmonary nodule clinic, because she then presented back in September of 2009, almost 2 years later, with some more complaints. And on her CAT scan, her whole side of her lung over here was infiltrated with mass, and there's fluid in here. And this is just advanced stage cancer. And it's unfortunate. She's a very young person, and her life expectancy is very short. And so that's what we want to avoid. We really want to avoid that. A 1.5 centimeter lesion that she had before was probably a curable lesion. And so that's when I see this, it makes me kind of sad and want to do what we can. When we did the procedure, kind of gross, and we turn away if you don't want to see this. But that's what we find. You go in and you look inside the chest, and that's cancer spread throughout the chest cavity. So if an early lung cancer goes undiagnosed, your window for a cure is missed, and that's what we want to stop from happening. So early detection, low-dose CAT scanning, early treatment. The least invasive way we can do it, and the least harmful way we can do it, but yet offering the best chance for a cure. And this just reiterates some of that stuff. But there are some risks involved, and so screening is not just for everybody. I'm not advocating that everybody go throw themselves under the CAT scanner and get screened. If you don't meet those criteria, then the risk of radiation starts to outweigh the benefits in some people. However, there are other people that may qualify depending on your family history, exposure to asbestos. There's a lot of other things that come into play too. And we're happy to talk to people and decide whether or not their risk and benefit are appropriate. So we're Central PA's only lung cancer screening program. Once again, there's the stuff, and that's the last slide, I think. Oh, no. Oh, yeah. Quit smoking. That's one of the best things you can do for yourself. Please, if you're smoking, do quit. And there are options. Pennsylvania has a quit line. Pinnacle Health also has a tobacco cessation service that you can call. And those are the numbers for our lung cancer screening and our pulmonary nodule clinic once again. And I'm pretty sure this is the last slide. Yes, there it is. All right. This is Dr. Henry Osman, a guy who I think is wicked smart, and I'm glad that he's involved in our pulmonary nodule clinic, our lung cancer patients, and we work closely together.
Thanks, everyone, for coming out. I'm going to talk to you about lung cancer screening. You're going to see a lot of repeats, repetition of some of the things that Dr. Moritz said. I'm a pulmonologist. My involvement with patients with lung cancer is basically for the diagnosis of lung cancer. We have offices on Front Street. We're about 6 blocks down from the governor's mansion, and we obviously cover Pinnacle Health hospitals. So what I did was I tried to create a question format here of how common is, questions about lung cancer that I think would be helpful to most people. What would they ask me? Okay, and I kind of boil it down to how common is it? Who should be screened? Where is screening done? What if I quit smoking 12 years ago? Do I still need screening? Is it appropriate for me? What if I never smoked? Is it appropriate for me? If something's found, what are you going to do next? What is the National Lung Cancer Screening Trial, and how does it apply to me? Should I be screened yearly, like the National Lung Cancer Screening Trial, or do I need screening more frequently than that? And that's something that we should talk about. I have nodules. Do I need a biopsy? Is there concern about radiation from CT scans? And if I have a diagnosis, what is going to be done? So I think the first question that we need to talk about is the commonality of lung cancer. We kind of showed some slides. I put here best outcomes with early detection. But what I wanted to emphasize is, if you look at this graph, this looks at people who die from lung cancer. These are females. And what I want you to note here is on this graph, females are actually plateauing now, okay? But if you compare that to males, males have actually stopped smoking, and they're starting to see benefits because they've stopped smoking. But if you look at smoking patterns of women today, they're not stopping at the same rate that men are. The other thing I want to emphasize is, if you were to put prostate cancer and breast cancer together, it would still be a distant second from lung cancer. And when you go outside in the parking lot, you're not going to see a single car with a ribbon on the back of it or a sticker on the back of it of someone championing lung cancer. So I think that's a startling thing to think about when you think about lung cancer. So who should be screened? Obviously, people who currently smoke and people who've smoked in the past should consider screening if it's right for them. Asbestos exposure is something that is important.
Where does secondary smoke come in?
Secondary,
Smoked for
yeah.
25 years.
That is debatable, but the current body of evidence shows that secondhand smoke results in problems with lung-related diseases such as COPD and emphysema. But there is not a trial out there or literature out there that can prove conclusively that exposure to secondhand smoke causes cancer. Whereas there is a body of literature that shows that people who smoke have a 10 times greater risk of developing lung cancer than patients who don't smoke. So the short answer to that question is, secondhand smoke, is it good for you? No, obviously not. It can cause problems related to emphysema and chronic lung disease. But does secondhand smoke cause lung cancer? That has not been proven. Okay? Compatible symptoms, and as we mentioned, there are not a lot of compatible symptoms. And then chest x-ray abnormalities, nodules that are greater than 5 millimeters have a higher propensity of being cancerous than nodules that are less than 5 millimeters. And we can measure nodules to be as small as 2 millimeters with current technology. Where is screening done? Currently, we offer screening. There's one site, two sites I didn't mention. What was the site? It was West Hanover and Dillsburg Center offers a low-dose CT, and we talked about the difference between a low-dose CT and a standard-dose CT. So should I be screened even if I quit? And the answer is, well, it depends. Let's look at your risk factors. Do you have a risk factor for asbestos exposure? Are you an electrician or a plumber? Did you work in a shipyard? Were you involved in asbestos remediation? Presence of compatible symptoms. Sometimes cough is present. Sometimes coughing up blood is present. Weight loss is present. But oftentimes it's not. And then your plan would be tailored by your doctor in accordance with those recommendations by governing societies related to chest medicine. That's what Dr. Moritz and I do. Radiology, there's this plan to look at nodules that is called the Fleischner Society Guidelines. And that is something that chest medicine physicians and radiologists have used to kind of look at what is the long-term follow-up of the nodule. If something's found, what will happen next? What is the next step? So I'd just like to emphasize, I tell this to my patients all the time, we can take pictures till the cows come home, but it doesn't diagnose anything. So if something is abnormal, the next step is you're going to need a biopsy of some sort. We're going to have to get tissue, and that's true of lung cancer. It's true of any type of cancer. You have to get a piece of it. So the easiest way to do that is to work in a manner that is appropriate for that particular patient, and it has to be tailored. One of the things that I did not put in here is PET scanning. PET scanning is helpful, but it does not provide a diagnosis. Whereas needle aspiration, thoracentesis is something that Dr. Moritz does. EBUS and electromagnetic navigational bronchoscopy are new modalities that we will be offering at Pinnacle. And then VATS. With VATS is simply, you ever hear of laparoscopic surgery where patients just have small little incisions? Well, Dr. Moritz has the same technology available to him for chest surgery, where he goes in essentially with 3 small sticks, and he's able to use minimally invasive approaches to achieve lung-sparing surgery. So what is the National Lung Cancer Screening Trial? Well, it was published actually this August in the New England Journal of Medicine. So New England Journal of Medicine probably has the highest hit factor in terms of, the stuff that they publish tends to be highly regarded, okay? So it's a highly regarded journal. And then the results of it, I'd like to point out that this was not sponsored through drug company money. This was sponsored by the National Institutes of Health, a division called the National Cancer Institute. This was sponsored by taxpayer money. So no one has any skin involved in this except the people that matter, the American public. Okay? So persons over the age of 55 up to age 74, many centers, it's a multi-centered study, so it looks at different practices throughout the United States. Over 53,000 people were involved in the study. Most large-scale studies are in cardiology involve like 2,000, 3,000 people. This is 53,000 people. So these results are generalizable to a whole cross-section of the population. They screened them once a year for 3 years, but then they followed them for 3 years after that. So they followed them for a total of 6 years. And what they found was low-dose CT results in fewer lung cancer deaths. And we've kind of said that, and I think you picked that up. The decrease in deaths was 20%, so it is a significant number, both statistically and just on the face of it. 20% deaths, 20% reduction in deaths, I'll take that. 3 times greater detection with low-dose CT versus getting chest x-rays in somebody. And more cancers were detected at early stages where Dr. Moritz can do something about it. Should I be screened yearly, or should I be screened more frequently? So again, the National Lung Cancer Screening Trial only screened people once a year with those risk factors. Risk factors being over the age of 55 and a current or a prior smoker with at least 30 pack years of smoking, 1 pack a day for 30 years. But they only did 1 CT a year, okay? Now, what Pinnacle is offering is a screening CT that talks about an initial CT scan for $99 to offset the cost of it, because insurance companies do not pay for it. But if something is found, okay, and you need further follow-up after that, that is part of your medical follow-up. So you don't pay for ongoing CTs after that point. Screening and surveillance will be tailored by your doctors, but I will say that the National Lung Cancer Screening Trial results have not yet been widely adopted by powerful organizations like the United States Preventive Services Task Force, or AHRQ. They're the ones who basically create all the screening policies for the United States government. But it may be in the future. I mean, it only just came out this August. So we'll have to see. But as Dr. Moritz pointed out, several powerful organizations in the treatment of cancer and lung cancer do support the findings of this in the context of a pulmonary nodule clinic or a multidisciplinary expert team in chest medicine. So I have nodules. Do I need a biopsy? Well, it depends on these things: size, number, calcification, risk factors. And nodules are not always cancerous. Nodules can represent infection, scar from old infection. They can be malignant, or they can represent both benign and sinister lung disease. And you'll need to discuss that with your doctor. Is there a concern about radiation? Recently in the news, they talk a lot about radiation and all these CT scans that patients are getting, whether it's a CT scan of the brain, of the chest, of the abdomen. And what we're differentiating is this is a low-dose CT, not a standard dose CT. You're getting many orders less radiation, 1.5 microsieverts versus 8 from a standard CT. A chest X-ray has roughly a tenth of the low-dose CT. Apparently, it's equal to about 6 days. A standard chest X-ray is equal to about 6 days worth of background radiation, whereas the low-dose CT is equal to about 6 months, and that was in one of Dr. Morit's slides, versus over 2 years of background radiation for a standard CT. There is background radiation everywhere. In this room, there's background radiation. There's background radiation being emanated from the person next to you. When you fly, you tend to get more radiation. If you live in Pueblo, Colorado, or New Mexico, you tend to have more radiation, background radiation, than someone who lives at sea level. Why that is, I don't know, but it's apparently ionizing radiation. Right. It comes from outer space. Exactly. Exactly. And then I just want to read this statement that came, this is an excerpt right out of the trial. The scanners that are currently used are technologically more advanced than those that were used in this trial. Because remember, the trial data is now 7 years old. Okay? This difference may mean that screening with today's scanners will result in a larger reduction in the rate of death from lung cancer than that was observed in the National Lung Cancer Screening Trial. And an example of that is Pinnacle. We use 64-slice CT scanners. We even have a 128-slice CT scanner. Why is that a big deal to you? Because with each turn of the CT scanner, it's already acquiring 64 images. Rather than the old days where a CT scan would take half an hour, now they can scan a chest in 8 seconds, a single breath hold. Okay? And you have to hold your breath for the CT scan. And for many patients who are being looked at for lung disease, they can't hold their breath for 30 seconds or 1 minute. Now they can do it in 8 seconds or less. If I receive a diagnosis of cancer, what can be done about it? Well, a lot can be done about it today. Partly with what Dr. Moritz does, and partly with what other treatments provided by radiation oncologists. One of the things I like to talk about is Gamma Knife. Gamma Knife used to be used exclusively for brain cancers. We're able to concentrate a dose of radiation into a very small spot with very little collateral damage. In the old days, radiation therapy destroyed everything in front of it and everything a little bit behind it and a little bit to the sides. SBRT, or stereotactic body radiation therapy, or so-called Gamma Knife, that's the trademark for it, can actually shape radiation into a three-dimensional shape. It destroys no tissue to the sides, nothing in back, and very little up front. And it can be done in 5 sessions versus, in the old days, radiation therapy for other modalities took many, many sessions, 20 sessions, maybe more. So Gamma Knife shows a lot of promise for the so-called inoperable tumor. But there are other medicines. There are medicines called tyrosine kinase inhibitors, monoclonal antibodies, angiogenesis inhibitors, and it's not so important that you know the names of those. What is important is that someone actually is working in the background to try and help combat this horrible, horrible disease. So there are still a lot of things that can be done about lung cancer today. If I receive a diagnosis of lung cancer, who is going to guide me through the treatments? So you will not go through this alone. You have your primary care physicians, your nurses and nurse practitioners, interventional radiologists, your thoracic surgeon, your pulmonologist. You have a whole cadre of people that are there to help you and guide you through this process so you can achieve a good outcome. And all of these treatment modalities are offered at Pinnacle Health through their multidisciplinary cancer team and the pulmonary nodule clinic. What can be done in the meantime? two best things you can do for your health. I'll talk about one of them because the other one really doesn't have anything to do with this topic, and that is quitting smoking. You saw some quitting smoking. If you know anyone who still smokes and you're really, really trying hard to get them to quit, Pinnacle Health has a quit smoking action line, but there is one from the National Cancer Institute. There's one from the federal government through the NIH called smokefree.gov, the American Lung Association. And then a lot of people want smoking cessation clinics where they can go and talk with other smokers to find out how they can be successful, and someone can give them a step-by-step plan. So I tried to look for one close by here, and I did find one at Sadler Health in Carlisle. I really don't know what Sadler Health does, but what they do is they just sponsor group programs in much the same way that 12-step programs work. What questions can I answer for you? Her question was, why age 55? Why not younger? Lung cancer tends to be most prevalent in those who are over the age of 50 because it takes a long time for it to kind of settle in. The question related to genetic testing for lung cancers. Unfortunately, there are not a lot of blood markers that are specific for lung cancer, and genetic testing, while there is a theoretical argument that there are some genetic factors to lung cancer, it's largely an environmental cancer, meaning you can have many members of your family with lung cancer. It doesn't necessarily predispose you to lung cancer. It's not that type of, it's not like colon or breast. And it's the utility or the, I don't know how to say utility in a different way, but the utility of generalizing, very esoteric testing, genetic testing is exceedingly expensive when it's unproven. So the question was, do you need your doctor to refer you to for this screening program sponsored by Pinnacle and in accordance with the National Lung Cancer Screening Trial? And the answer is no, you don't need your doctor to refer you. How long does it take? I think that you would the CT scan, probably the actual time that you're in the CT scanner would probably be a minute or two. The total time that you're in Department of Radiology is going to be short. I can't really tell you how long it's going to be. I don't know much about.
It's not like a whole day thing.
No, this is not a whole day thing, and yeah. Did you have any details? Okay.
Really, it should only take about 15 minutes. Generally, you come in, someone greets you in radiology, they offer you a gown and a location to change. Then you go in and they tell you what's going to happen. You lay down on the scanner. It's an open machine. A CT is not a closed, they call it bore. So you're outside of where they do the radiation, and you're laying there, and they do the scan, and then you're done. You actually don't leave with results because it is an advanced read that's required by the radiologist. So it's mailed to your home, and then your physician is also provided a copy as well.
There's no noise. If many of you kind of know the noise associated with an MRI, the pounding noise, that is not present with the CT scanner. And again, it's fairly quick, but the turnaround time does take interpretation by a chest radiologist. So it will take some time for, again, you won't walk out with results. So the question was, why would I choose Gamma Knife versus surgery? Okay. So Dr. Moritz very briefly touched on there are two broad categories of lung cancers, non-small cells and small cells. Non-small cell is the most common type. It represents nearly 3/4 of lung cancer. It is treated preferably with surgery. Surgery is going to achieve a so-called cure. Small cells are not treated with surgery. If you were to have a situation where you are not a good surgical candidate because you have pre-existing lung disease that would prevent you from tolerating the surgery, because the surgery usually involves removing a portion of the lung, up to 20% or more of your lung volume, then perhaps Gamma Knife would be an option for you. But again, it's not where you go on a menu and you get to choose. It's more like the doctor helps you make your choice that is best for your situation, and you might not realize what is best for your situation until you sit down and meet with Dr. Moritz or meet with the pulmonologist. So that's kind of the extent of what I'll say, and then Dr. Moritz will kind of expand on that.
Yeah, this is a very evolving topic. The difference between Gamma Knife or CyberKnife radiation, the focused radiation, and surgery. Up until this point, Gamma Knife and CyberKnife, or basically similar devices, were used for people that were non-operative candidates. And so it was somebody that usually was seen by the surgeon, and we check your lungs with pulmonary function testing or maybe an echo of your heart. Either your heart or your lungs maybe didn't allow you to tolerate the surgery. And age isn't too much of a factor. We do operate on 80-year-olds and stuff. Sometimes getting into the 90s is a little tough to get through an operation, and so maybe radiation's more appropriate. But we currently are, I believe, going to be enrolled in a study where we're going to randomize people. It's a national study going on. And I think we're going to want to be in one of the centers for it for operative candidates, meaning people that have the ability to tolerate surgery and want to enter into the study can be randomized between surgery and CyberKnife. And that's a huge leap forward, because that's basically showing that CyberKnife is perhaps equal to surgery. Now, until that study's done, and it'll be years down the road before we'll absolutely be able to answer that question. And some people just absolutely will not have surgery. I mean, there's people that are like, sorry, Dr. Moritz, I don't care about your small poke holes. I don't care, it's not going to hurt as much. No, you're not going to operate on me. And that's fine. We have another option for those patients. But we present these patients at our multidisciplinary thoracic tumor board with the radiation oncologist, and sometimes he says, no, it's too close to the heart. We look at him, my partner's a thoracic surgeon, and we say, that's a lesion we don't know if we can address, or vice versa. And so we come up with a plan when we review these cases, and then we offer it to the patient. And ultimately, the patient gets to decide. But we try to figure out what we think each one of us is best suited to do and treat for that patient. CyberKnife is close. I'm not a radiation oncologist. If my colleague Dr. Sood was standing here, he'd be much more confident saying that CyberKnife is right there. But that's what he does, and he's very excited about his technology. So I think that's why people get CyberKnife. Right now, it's because you're not a surgical candidate. But it's getting to the point where it might be more of an equal option. But right now, I'm glad to say surgery wins, in my eyes, and in most of the literature, for that matter.
Yes, sir. If I have the scan and the results come back, do I come to the nodule clinic? Do I go to my primary care physician? So this is a very important question.
Yes. I will be receiving results of everyone's scan that comes through, and we will be reviewing those. And in the letter, it will also state that as an option, you may follow up with your primary care provider, or you may follow up at the pulmonary nodule clinic. I will be receiving those results and contacting each person who has a scan, because as we saw, it's important not to let these things fall through the cracks. And so I'm basically an extra set of eyes, a stopgap to prevent that from happening. So you will receive a call from me. Even if it is a normal scan, according to the study, they did recommend, they performed scans over a 3-year period, 1 year, consecutively. And there were additional cancers picked up on each of those additional screens. So at this point, it seems that would be a prudent way to handle this. And we certainly would not deny that. If some individuals may not want to do that, that's perfectly fine, but we're there and available to do that on that annual basis.
The question was the CyberKnife not appropriate for small cell? You can use the CyberKnife for multiple different modalities. It's surgery that we don't usually operate on small cell. if it's small cell.
You don't operate on
Yeah.
small cell.
The only time we operate on small cell is if we're going in to do a surgical biopsy and remove it because it wasn't biopsied some other way, and we happen to remove the whole thing, and then we find out it's small cell after the fact. That,
I'd just like to touch on that. The purpose of the biopsy is to find out what type of cancer you have. But the second purpose of the biopsy is to partially determine your stage. Because treatment is not only based on tumor type, tumor size, but it's also based on stage. So stage takes into account size of the tumor, the lymph nodes that may or may not be involved, and is there evidence of distant disease, meaning disease outside the confines of the lung. The question was, this very nice lady said that she previously was diagnosed with a nodule, and she did receive follow-up, and the last time she had a CT scan was roughly 3 years ago.
Yes.
So the way nodules are followed, I kind of briefly touched on Radiology Society guidelines. Some people will have nodules in their chest, and it's not necessarily indicative of a sinister diagnosis. It all depends, again, on your risk factors. If you're a smoker or a prior smoker, the chances of a nodule having greater potential for a malignant diagnosis are greater. And in that case, you would need long-term follow-up for a minimum of 2 years, because the doubling time of a lung cancer is faster than 2 years. But that's not to say that you need follow-up indefinitely, meaning you don't need yearly CT scans for the rest of your life. Because if a nodule doesn't change in size in 2 years, it's probably not ever going to change.